All right, welcome. March 25th, 2026. Q&A with Dr. Wong.
Okay, so first question. Can you please explain when to use the Dentarum Pyrex? Click maximum 12, medium 10, sectional screw 4 mil, and fluorescent screw 10 mil. As I need to guide the technician on working. We use Dentarum screws for upper midline expansion, and normally we just use the 10 mil click. So the 10 mil is the one that we use. It's the one that is going to fit better in a smaller palate, such as in primary or early mixed dentition. And it is a much better screw than the fluorescent, which tends to fail quite readily. The Dentarum click is, in my experience, the best of the midline palatal expansion screws. As far as when we would use the sectional screws and which one to use, I prefer the fluorescent skeletal section screw in the lower midline, but we use the 5mm version, not the 10 mil. I don't think there's a 10 mil version. There's only a 5mm version, and that's preference to the Dentarum sectional screw, which is only a 4mm. The fluorescent one has 1 extra mil, so that's helpful in the lower arch. And it's also the same screw that we use if we're doing a sagittal space opening screw in either the upper or the lower arch. So the two screws that we use on a routine basis is the Dentarum Hyrex Click 10 mil screw that's used in the palate in the midline, and we use the fluorescent sectional skeletal screw, the 5mm version, that's used in the lower midline and also in either upper or lower sagittal space opening. Okay. So next question is, may I know which screw to be placed in the Bible upper with a 38 mil internal width and wishing to get another 3 or 4 mils? We would use the Dentarum Click 10 mil screw.
Simon,
Okay.
is this normally laid out in the 2-day notes or the lab day?
Both.
Yeah, I think you gave them during both, right? Okay. So definitely, Dr. Clue, look up the slides and all the handouts for in lab day and in the 2-day. It's all included. All right. Thanks.
Okay, next question. Choking. I recently had a patient who has been in an upper stage 1 to correct crossbite. I've been really enforcing the importance of eating with a plate. He was finally able to do so. Parents have been great throughout my functional brace, Vivos, Tanner appliances. Bum emailed and told me that there were 2 incidents of choking when he got food caught in his throat. One of them was scrambled eggs. You are aware that the family is very compliant. Have we had that experience before? The upper appliance is almost maxed out, and I can see how food could get stuck. It's not something that is normally encountered. One of the things that we have to consider is if there is some dysphagia for the child. One of the aspects of what we're trying to correct is the swallow pattern or the function. So obviously posture is our primary focus, but function is very important as well, as it's intertwined with posture. When we struggle to swallow, we have to consider, are we following the protocol of chewing with the lips together, swallowing with the teeth together, not talking when there's food in the mouth. So generally, if we follow the protocols, we don't have issues with swallowing, choking. If we don't follow those protocols, and we've always historically struggled with eating and swallowing, then adding a plate in can also create additional burden. When the plate has been expanded fully, obviously you can get food trapping more easily, but to have reached a point where the screw has expanded fully, it means that we've had at least 3 months of the appliance being in place. Right, so if the screw has expanded close to 8 or 9 millimeters, and we're expanding at a rate of about 0.8 millimeters every 8 days, we've had it in theoretically for at least 10, 12 months. And if this is the first instance of choking, then it's not likely related to the plate itself, and more likely related to him not following the rules that we're trying to encourage when we're eating. So choking in children is not uncommon and is one of the biggest concerns of every parent of an 18-month to 2-year-old child. The reason why choking or dysphagia, swallowing issues occurs in that time frame, and it's consistent with choking later on in life, including choking as an elderly person, is that we either don't have or have lost control of the ability to juggle multiple complex functions. So swallowing is a reflex, but it's actually quite a complex function. Breathing is a reflex, and it's not a particularly difficult or complex function. Talking is learnt, not a reflex, and is actually a very complicated function. So when you combine 3 relatively complex functions and jumble them up, we tend to find that the very young, the 18-month, 2-year-old, really, really struggles. At 18 months, we switch from suckling to swallowing. It's a completely different process, and one that occurs organically in normal life, but there's a learning phase. Prior to the ability to speak at around 18 months, the soft palate and the epiglottis are actually touching. So they act as a barrier to prevent food particles from entering the airway. Prior to this time frame, infants have the capacity to breathe and feed simultaneously because the epiglottis is touching the soft palate. It's anatomically, everything in the throat and the mouth is much smaller. That anatomical compression provides a barrier for the fluids to pass into the esophagus without entering the pharynx for the airway tube breathing. When we transition from liquids to solids, we are in a growth phase, molars erupt, and we lengthen and enlarge our physical structure, and the soft palate actually starts to move away from the epiglottis. When that happens, we lose the capacity to feed and breathe simultaneously. We have to, at that point, learn that we can only feed or breathe alternatively, but no longer simultaneously. At the same time, when the epiglottis and soft palate separate, we also gain the physical capacity for speech. That speech, unique to human beings, is only possible with the separation of the epiglottis and the soft palate. Anatomically, we then have, simultaneous to losing the capacity for feeding and breathing simultaneously, we gain the capacity for speech. So at that time frame, we have multiple changes that are quite complex, and we run very real risks of choking, right? So getting food into the windpipe. It's amplified by the fact that at that time, we try to learn to do many things at the same time: eating, breathing, and talking. If we transition well by learning to do one thing, then the other thing, without intermingling the two functions, then we very quickly learn to juggle breathing, eating, and talking. And as adults, or even as young children, we gain that capacity for those three things simultaneously so that we can hold conversations, continue life support breaths, and eat at the meal table at the same time. But if we don't train our children to learn these new functions separately, then we run the very real risk that they run into danger. And so that's why part of the historical child raising protocols and part of the GOPEX chewing exercise is we have a rule of never having the lips apart when there's food in the mouth, never talking when there's food in the mouth. chewing our food hard and fast and swallowing with our teeth together. If we utilize that specific protocol, which is part of our natural, correct training of children, historically throughout the history of mankind, then we eliminate the risk of choking on food. Children who continue to choke, elderly adults who lose the capacity to juggle those functions because of cognitive decline, return to that risk of choking on their food. So I don't have all the information that I need for this patient, but I suspect that we jumbled those three functions, and with the additional burden of having a plate in the mouth, we lost control and we ended up in a choking scenario. So how do we manage it? I would enforce the GOPEX chewing protocol as a default method. Next question. My case you're helping me with, I have lower brackets. I'm trying to fit in lower laterals by extracting the lower C's and then managing the space and eruption of permanent 4s and 3s, with the 4s erupting ahead of the 3s in the X-ray. This is a case where the child developed more sagittal leeway space instead of transverse space. Currently have brackets on D, C, and the incisors. If we extract the lower C's, then make a new lower stage 1 with accessory wires extending to the mesials of the D, could we realistically distalize the D's to push them back to contact the E's prior to the 4s erupting? In other words, can we use the stage 1 lower to distalize the D's after we get the C's out and the lower incisors forward? So one of the things that we have to consider is it's a little bit difficult to move primary molars and primary teeth in general. It's not that we can't, but they tend to resist that movement. In the specific case, for some reason, instead of transverse space developing when we expanded the midline in the lower arch appliance, space opened up between the D and the E. Theoretically, you can move the D back, but you're in a scenario now where you have bracketed and strapped up with arch wire, the D, the C, and the central incisors. So when you're all strapped up, you add another burden of inability to move in a sagittal section the molar. So we've got to think, realistically, what is achievable? Can we move the D back? If we do, it's possible, of course. Do we accelerate the resorption of that root system? Likelihood is yes. So you'll lose the D earlier. If we lose the D early and the lateral incisors are blocked out, then we run an issue of having less teeth to bracket, right? Especially if we have to take the C out in order to get the laterals in place. Of course, you can use the E's to bracket, or even the 6-year-old molars. And it's not uncommon for that, in the sense that this is a traditional approach, 2x4, using brackets on the incisors and brackets on the sixes, and then using that to align the incisors and using the arch wire to maintain a good arch form. So we would then not use a lower expansion appliance, and that's certainly a possibility. So different approaches can be used depending on the circumstance and the situation. So you might use that, for example, brackets on the 2s and brackets on the 6s as your space maintainer. Or you can use a lower lingual arch. So you'll fix a band on the 6s and have a lower lingual arch wire to control the incisors and hold leeway. But the issue that you have is your first premolars are still going to erupt ahead of the lower canines, and it will erupt into the space of the permanent canines. And you don't have any capacity to easily control that. You can, of course, bracket the 4s as they come out, and then you can, pull the 4 back towards the 6 using chain and arch wire, but you're going to need to have really good mechanics control in fixed appliances to be able to do that. So lots of different approaches are certainly possible. It's not one solution to the problem. There's many methods to treat this circumstance. It's just a matter of what you feel more comfortable with, using fixed appliances or removable appliances. I find it very easy to combine the two in that method, but if your preference is to use fixed appliances, you can certainly do that. If you want to use removable appliances to distalize the 4s or distalize the D, then you're going to probably have to get out of the current fixed appliances, or you have to use a approximating wire to distalize the D. The issue, as I said again, is it's not a very predictable movement. Moving primary molars is not always an easy thing. So if it's moved forward because of tipping, certainly it's possible, but we'd have to update the x-rays to have a better understanding of where everything is and what the root formation remaining is. So I think that was one of the decisions that we had recommended, to update the pano x-ray. But yes, there's lots of different ways of managing orthodontic situations. Next question. For patients in a stage 1 upper and lower, I'm confused on when to deliver a retainer after the E is lost. For example, patient currently done expanding upper appliance and about to lose the E's in the next 3 or 4 months. I thought once we lost the E's, we were only relying on GoFX and not relying on a retainer. So when do we decide to make a stage 2 appliance retainer clasping the 6s and incisors? When are we concerned about not having enough space for later erupting 3s? So you have to consider what you're dealing with. So the normal sequence of loss is that you have the lower E's are lost as normal, the last primary tooth in the lower arch. And the upper ears are lost as the second last primary tooth in the arch. Okay, so normally the lower ears are lost about 12 and a half. The upper ears are lost. No, sorry, the lower ears are, yeah, upper and lower ears are both lost around 12 and a half. The last primary tooth to be lost are the upper C's. So the sequence is upper E's, lower D's, then upper C's as the finish to mixed dentition. We're assuming that the lower canines have already erupted. We're assuming the lower first premolar has already erupted. And then finally, the lower E's exfoliate, and then the lower second premolar erupts as the lower second molar erupts, and the leeway space is closed with the first molar moving to eat up the E space as the 12-year-old second molar erupts into position. So if everything has gone to plan, your central incisor, lateral incisor is in a good position, your permanent canines are in a good position, and your premolars have erupted well. When the lower E falls out, then you want the 6 to move forward as the 5 erupts so that the 7s have room to erupt. In that circumstance, your incisors, canine, first premolar are all well positioned, and your second molar is starting to pop its head through, then you don't want to retain any space when the E's fall out in the lower arch, because you want the 6s to move forward to close up the leeway, and you want room for the second permanent molar. When would you hold the space? When you are erupting out of sequence. When your your first permanent premolar has erupted ahead of the permanent canine in the lower arch. When that happens, you end up losing the space you need for the permanent canine as the 4 premolar drifts forward, or even when the 4 eats through the D and the C, and sometimes that happens. Then you've got leeway space, but you've got a jumble of the teeth. The premolar is eating up the canine space. In that circumstance, you can't afford to have the 5 move forward into the 4 space and the 6 move forward into the 5 space, because you're going to end up with your canines completely blocked out. In that circumstance, you'll have a retainer that holds the leeway space so that you can distalize the 4 back and hold the 3 space to allow the permanent canine to erupt. So that's when you would hold that. The sacrifice you make is that you're going to block the second premolar to a degree, and it might end up a bit jammed up. So your hope is that you can quickly move the 4 into its correct position before letting the 6 move forward when you let it go at that point in time. Sometimes we have to return to a retainer that holds the 4 and the incisors, holding the 3 space so that the canine can continue to erupt, while letting the 5 and the 6 move forward so that the 7s can erupt. right? So that's one circumstance on the lower arch. In the upper arch, we are transitioning first premolar first, then second premolar second, and then finally the permanent canines last in the mixed dentition changeover. Does that always happen? No, of course not, right? You can come out of sequence, you can have block teeth. So if again you are struggling for canine space because the 4 has eaten up the 3, so sometimes the C, sorry, sometimes the C again. Sometimes there's not enough room for the canine, and you need to distalize the 4 back into the distal of the D space so that you can maintain the C space longer for the canine to come through. So you might have a circumstance where the canine is ectopic, which is not uncommon for upper canines. And if you don't hold the leeway space and control the position of the erupting first premolar, then that will eat up the canine space. Sometimes you know you have to encourage a redirection of the upper canines because they're ectopic, and you want to extract the C's to encourage the permanent canines to move into their correct alignment. So when you have an ectopic upper canine, the C's can be over-retained. So common practice is to extract the C's so that you have room, a channel that the permanent canines can kind of redirect their journey towards. But because the 4s, the first premolars are up years ahead of the canine, if you extract the C's before the 4s have established interdigitation with the opposing arch, it will drift into the 3 space. It will drift into the canine space. So at that point, you have to hold the leeway and you have to distalize the 4 back into its correct position, and you have to hold that. So even when the E's are lost, because you are trying to control the premolar position so that you don't lose canine space, you actually have to anchor your plate off the 6s and the incisors because they're the only stable teeth, so that you can control the leeway space and you can distalize the measly drifting premolars so that you don't lose your canine space because you've extracted the C's to encourage the canine to move into its correct channel. There are other variations on these themes that require you to hold space. So, but that's basically it. If everything is tracked to plan, then you don't want to hold the leeway because you want the 6s to move into class 1. If things are complex and out of sequence, or you've lost previous space and you're reopening space, then you have to extend your hold on the arch form so that you can control the eruption of the canines and premolars. And your sacrifice is that you're going to, at least on the short term, block the second molars from moving easily into their own positions. So, yeah. So that's that question answered. All right, so I think that's all there is.
Any other follow-up questions or questions from Candice, Fran, Dr. Koo, Sonny? If you've got a question, just type yes. Give you a few more minutes to type it in. Let's see what's going on. Any questions coming through? All right. Looks like that's it for today. Thanks, everyone. Thanks, Simon.
Thanks, guys.
All right. Bye. Take care.